Let me thank Dr. Bala Murugan for their enthusiastic approach and making this meeting possible. We still learn that uveitis, infectious uveitis is a challenge, and every day I learn from the seeing the patients from the uveitis. Today I'm going to show you some classic cases, but many of the cases which I have seen, I have not solved them and it remains a challenge. So I put out a few slides to see the do's and don'ts in infectious uveitis, mm, which I thought that may be useful for all of us, particularly the juniors, how I have learned. And so I made it a simple one, TV. One, in case of infectious uveitis, what are the common infectious uveitis you should think of? Tuberculosis in our country, obviously, toxoplasmosis, which Dr. Bala Murugan has talked at length, but I'll talk a few points about it. Treponema and viral. So TV is the acronym for the common infectious uveitis. Tuberculosis is the well-known infectious uveitis. One third of the patients of the world of tuberculosis is in India. There are 5 points in tubercular uveitis. I made it very simple. What is the when to suspect tubercular uveitis? Very simple. Second, what lab test to do? Number three, what radiological test to do? Number four, what is the role of in, is infectious sampling of the uveitis cases, and how to treat tubercular uveitis? So when to suspect tubercular uveitis? If I show you a picture, then you'll be amazed that the tuberculosis can present in a myriad of ways, from a small nodules in the choroid to a subretinal abscess, panophthalmitis, granulomatous anterior uveitis, even conjunctival tuberculoma can be present as uveitis, tubercular uveitis. It has a protein manifestation. And so this is a granulomatous uveitis. We will put top in our list in our country, the tubercular uveitis, and we should investigate for the tuberculosis for the same. Next is the broad posterior synechia. Retinal vasculitis with choroiditis is not the great picture, but retinal vasculitis with the choroiditis. Multifocal serpeginoid choroiditis is now thought to be of tubercular origin, unless proven otherwise. And then subretinal abscess and tuberculoma of the choroid or choroidal nodule. These are the questions where, these are the conditions where you will suspect tubercular etiology. But there are certain situations where you meet an unusual conditions like tubercular uveitis presenting as a pigmented hypopion. One patient which I've seen is the second case reported in the world. First case is reported from Dr. Ratnam from Madurai, and it has got a convex pigmented hypopion. And we did the AC-TAP. AC-TAP and PCR and culture was shown Mycobacterium tuberculosis. There can be other conditions like, prostate branch angiitis. Is a 17-year-old girl, biopsy-proven abdominal TB. So this patient had prostate branch angiitis, and the patient was treated with treatment of systemic TB, systemic anti-TB treatment with a steroid, and responded completely well. So apart from the 5 common causes of tubercular uveitis, and there could be some atypical presentation. So the list is not exhaustive. So this is a elegant study done by the Dr. Amod Gupta from PGI Chandigarh. He classified the tubercular uveitis and non-tubercular uveitis, and then calculated the ocular signs predictive of the tubercular uveitis, and found broad posterior synechia, retinal vasculitis with or without choroiditis, and serpiginous choroiditis, particularly multifocal serpiginoid choroiditis is of tubercular etiology. So we know about the clinical diagnosis phenotype of the tubercular uveitis, which is can be exhaustive, but which lab test can be done, we should do. One should do a Mantoux and quantiferon TB gold test, which is not enough. It is a supportive only, but because the exposure doesn't mean active infection. Many of us are also Mantoux positive because the tuberculosis is a ubiquitous bacteria, and many of us are exposed to tuberculosis and have tubercular and hypersensitivity reaction. So exposure doesn't mean active infection. So what to do in that scenarios? In that case, challenging situations, we might do an intraocular biopsy like anterior chamber tap, vitreous aspiration, or fine needle aspiration biopsy of the ocular lesion. Subject to polymerase chain reaction for mycobacterium tuberculosis genome, we have done some work on granulomatous anterior uveitis, tubercular intermediate uveitis, and tubercular subretinal abscess. Does the laboratory test help us? This is a study from the AFIP by in where they have done the clinically proven tuberculosis, and they found 40% of the positive cases which are proven histopathologically TB are Mantoux test negative. 40% positive cases were Mantoux test negative. So Mantoux test doesn't really rule out tuberculosis. So negative Mantoux test doesn't mean that there is no tuberculosis. And there is an elegant paper from Somava Bosu who had found tuberculous serpiginous choroiditis in patients with negative TB immunoreactivity test. This is a recent paper, and this paper also says supports the theory that if we take that all Mantoux negative case or quantiferon TB gold test negative, we cannot rule out TB choroiditis or TB uveitis. And the utility of the quantiferon TB gold test should be based on the clinical scenarios and should be based on the additional test which are supportive of the tuberculosis. Which radiological test to do? X-ray test is not good enough. Do high resolution CT test, in particularly in ocular tuberculosis. X-ray test blocks about 40% of the lesions in the lung, and high resolution CT chest is often supportive of tubercular infection. And here is a case, here is a study from our center, then where we have found 80% of the TB and 8.3% of sarcoidosis when it was done in granulomatous uveitis cases can be diagnosed. So the high resolution CT chest is quite valuable in case of suspected tubercular uveitis like granulomatous uveitis. And this is a one case of subretinal abscess. You can see that showing tree and bud appearance in CT scan, which is completely quite characteristic of the tubercular infection. What is the role of intraocular fluid sampling? Is in our hand, it works quite well, and polymerase chain reaction is often diagnostic in suspected cases. Sensitivity is around 80% and specificity often about 100%. So, but we have got few cases of where we, in spite of the PCR test positive, other etiology was found. So most of the times the PCR is quite reliable. This is an example, 20-year-old female, granulomatous anterior uveitis, mutton fat KPs. You can see the broad posterior synechia and peripheral anterior synechia. In this case, we decided to do anterior chamber tap and subjected to do polymerase chain reaction for mycobacterium tuberculosis genome. And you can see that polymerase chain reaction of mycobacterium tuberculosis DNA, MPB64 and IS6110, both were positive. And this patient was treated with antitubercular treatment. As I was telling earlier, that endpoint of such treatment is difficult to make out in case of tubercular uveitis, because anyway, that TB uveitis, granulomatous uveitis will respond to topical steroid and mediatic cycloplegic agent. It is the recurrent nature of the disease which can be prevented by giving an course of antitubercular treatment, and finding out the tubercular etiology would be crucial to find out that recalcitrant, recurrent granulomatous anterior uveitis. Subretinal abscess. This is also one should suspect tubercular uveitis. And another cause is nocardia. And this particular patient wants simple fine needle aspiration biopsy. This is not often easy to do it. Fine needle aspiration biopsy from the abscess was done, and then small tiny material which has been collected was subjected to the PCR, and PCR was positive for mycobacterium tuberculosis DNA. How to treat tubercular uveitis? I feel that it should be started with a 4-drug anti-tubercular treatment. There is no compromise about it, and always combined with the steroids. The inflammatory component doesn't go without steroid. So I always recommend giving oral steroid at the same time you start anti-tubercular treatment. What is the correct duration of anti-tubercular treatment? There is a lot of debate. So lot of people, there is a study which said that 9 months treatment of anti-tubercular therapy is better than the 6 months. Recurrence rate is markedly low. So treat as extrapulmonary TB and give at least 9 months of treatment. This is a case of a patient who has been given 9 months treatment of anti-tubercular treatment, subretinal abscess with a steroid, and it showed a remarkable response to therapy. Coming to the toxoplasmosis, Dr. Balamurugan has told in detail. Is a toxoplasmosis, when you see a congenital toxoplasmosis, nothing much you can do. But in case of acquired toxoplasmosis, the clinical signs is quite characteristic. You can see a previous old scar, and by the side edge of the scar, you will be seeing active retinitis lesion or retinochoroiditis lesion. And second is the headlight in the fog appearance, localized vitreous with necrotizing retinitis or retinochoroiditis. Sometimes we get an extensive infections. Like this case, he has got papillitis with serous retinal detachment with toxoplasmic retinochoroiditis. And this particular patient was responded to the antitubercular antitoxoplasma treatment remarkably. In this case, AC-TAP was positive for the toxoplasma. I'll be showing this case in the case discussion later on. In case of HIV, the picture is often different. It's a diffuse type of retinitis, and the vitreitis may be very less, diffuse or multifocal type of the lesions. And in this case, PCR is quite helpful, these atypical cases, because ELISA test may be negative. And this is a case, HIV, PCR of vitreous is positive for toxoplasmosis. This is a before treatment, and this is the after treatment. There is complete resolution of inflammation. Ocular toxoplasmosis is a clinical diagnosis. ELISA to confirm. PCR of the intraocular fluid is required in all atypical cases. It is not required to PCR to all cases of toxoplasmosis. You should not do the PCR, but ELISA is a must. ELISA for the toxoplasmosis. You can do the ocular fluid analysis in case of doubt. Intraocular fluid, aqueous or vitreous. Coming to the treponema. Treponema is another condition which you should not miss, and this is one of the diseases which is very much treatable. This I give to example, a 43-year-old male, dimness of vision and floaters, diagnosed as CMV retinitis, HIV positive, treated with intravenous ganciclovir. I used to shake hands with the patients routinely before the COVID era, and now I don't do that. But I found something wrong that time in his hands. What was in that hand? It was a scaly rash in the hand, and I could make the diagnosis before seeing the patient itself. And in fact, is that the clinical signs was telltale of syphilitic retinitis, and there is a golden yellow subinternal limiting membrane deposits were seen with serous retinal detachment. And this patient was RPR-TPHA positive, treated with injection crystalline penicillin, and responded dramatically well with the treatment with complete resolution of the inflammation. And in case of the syphilis treatment, is so gratifying. The diagnosis is very crucial and important for the patient. So is high degree of high index of suspicion should be kept in syphilis in any cases. If any case which you are not able to make a diagnosis or come to a clinical diagnosis, keep the mind of the syphilis to be ruled out. Always you should keep it in mind. Mind should be kept prepared. This another case is a 30-year-old female, gradual dimness of vision in both eyes for 3 months. And this patient presented with a vitreous, dense clog of vitreous opacity. I couldn't make out what is the diagnosis. When you do not able to make a diagnosis, then syphilis should come into your list, and any atypical uveitis, this patient pre-treatment there is a vitreous opacity, and after treatment there is a complete resolution of inflammation. Serological test for the syphilis, VDRL, TPHA or FTAVS, high degree of sensitivity and specificity, both the non-treponemal and treponemal test will be done. Particularly, treponemal test is important for screening purpose. Ocular syphilis. Syphilis can mimic any type of uveitis, as I mentioned before. Order both the type in suspected syphilitic uveitis. VDRL showed the conversion of the VDRL RPR will tell us the response to the treatment. Last is the viral uveitis. Viral uveitis is a real emergency in uveitis. And let's start with the case. Is 30-year-old female, immunocompetent, and this patient presented with necrotizing retinitis in the macular area. Can we make a diagnosis? Yes, if you can do a thorough clinical examination and a holistic approach, you could come to a diagnosis. I look at the patient's head and I found that there is a blister, the herpes vesicle, zoster vesicles on the forehead. And this patient indeed there was found to be PCR positive for varicella zoster virus and responded with a course of IV acyclovir for 7 days. It was published in American Journal of Ophthalmology case report. Viral retinitis can be many forms: CMV retinitis, acute retinal necrosis, progressive outer retinal necrosis. There is a one entity which you should not forget, that is called viral anterior uveitis, which is coming up. This patient, 59-year-old man, had chronic uveitis, pigmented KP, and IOP was 40 millimeter of mercury. When IOP is so high in uveitis cases, you should keep the virus as a possibility. Virus cannot be smeared or culture. We need to do a PCR, and this is what we did. The patient, I suspect viral anti-uveitis. I do AC tap for PCR for HSV1, HSV2, and CMV, nested and real-time PCR. AC tap done was HSV1 was positive and was treated with antiviral treatment after IV acyclovir, oral valacyclovir, and the patient responded to the treatment. Coming to the another entity, which is the last one, is the dengue retinitis, post-fever retinitis, which could be dengue, chikungunya, typhoid, rickettsia, chickenpox, Epstein-Barr virus. These are the various entities which can be vision threatening. Most of the cases are RNA virus, so PCR is quite helpful in diagnosis, and well-Felix test can be done in rickettsia. So in summary, that there are four viral and four infectious uveitis entity. We should keep in mind: tuberculosis, toxoplasmosis, treponema, and viral. This I call it as a TV in infectious uveitis. TV, tuberculosis, toxoplasmosis, treponema, and viral. So take-home message is often a protein manifestation, infectious uveitis. To treat the infection first, followed by the systemic steroid, supportive anti-inflammatory therapy only, and periocular intravitreal injections is strictly contraindicated, particularly in toxoplasmic retinochoroiditis. Intraocular fluid even should be done when there is a doubt. Thank you very much.